what are the unmet needs and challenges in treating relapsed refractory small cell lung cancer? I'll take it from Dr. Ganti first.
So we talked about new options like lurbinectedin and immunotherapy, but at the end of the day, overall survival in the relapse setting, even with the phase 2 data from lurbinectedin, is still less than a year. And earlier we talked about immunotherapy being a big advance. Again, their median overall survival is only about 13 months, slightly more than a year. Clearly, we need better drugs and we have to do better in this disease. So there is a big unmet need. The recent advances in the use of immunotherapy notwithstanding, clearly we need to do better by our patients. And so I think there is a lot of effort that needs to be put in identifying newer drugs, newer pathways, understanding the mechanism of resistance, looking at biomarkers to see which patients can benefit and which patients don't benefit so that we don't expose them to some of these side effects. So all of those things are things that need to be looked into going forward for small cell lung cancer.
Thank you, Dr. Ganti. Dr. Shang, do you have any insights into the unmet needs and challenges in treating relapsed refractory small cell lung cancer?
Sure. I think that clinically, brain metastases is something that is a difficult challenge for these patients. Many of these patients have metastases to the brain either at diagnosis or during the course of their disease. And once they've had prophylactic cranial radiation or whole brain radiation, you often have situations where you have progression or recurrence in other parts of the brain, and they've sort of maxed out on radiation therapy. You certainly can use gamma knife or local approaches, and then there are some drugs that have penetration through the blood-brain barrier, such as temozolomide, and some of our standard drugs like taxanes or topotecan do as well. But I think that especially for this population, brain metastases is difficult, and many of the clinical trials will also exclude patients who have a history of brain metastases. Sometimes we do have patients with leptomeningeal disease. I think that, as Dr. Ganti mentioned, understanding the biomarkers that can predict response. This is clearly a heterogeneous population of patients. And Dr. Sabaya, you already referred to sort of the new paradigm in thinking about this disease, that there are ways to categorize molecular subtypes that overexpress certain genes, such as YAP1 or the PUF3 or other ones, and that those different subtypes can also have a different natural history of the disease. So I think being able to dissect out what kinds of small cell lung cancer there are, and then perhaps targeted or more targeted approaches for those subtypes would be great, and I think will continue to be one avenue of investigation. Biomarkers, as I mentioned at the beginning, such as TMB, such as looking at the tumor microenvironment and looking at infiltrating T cells. There may be blood-based analysis of the circulating tumor DNA, or other assays that are based on not obtaining tissue but on the blood that can be very useful in managing this disease. I think tissue remains something that's difficult for these patients, so many of them are still diagnosed via fine needle aspirates, and I do think that the more tissue that we can get to study what's going on will be useful. And then ultimately, I do think that thinking about the patient as a whole and how they're resilient and respond to this disease is super important. Many of these patients have a terrific response to chemo. in the 60 to 80 or sometimes even 90% response range. And they're just blindsided. Even though you tell them at the beginning, they're just blindsided when they have recurrent disease and really have to shift their paradigm to thinking about different ways of coping and the impact of this disease on their lives. So I think there still needs to be a lot of work in that area to investigate how patients can develop approaches to be resilient and to cope with an incurable chronic disease. We do hope that that tail of the curve pans out for these patients, that some of those patients treated with immunotherapy can have an extended survival. And I've certainly had patients who have done very, very well. So there's lots of room for hope.
Thank you so much. I think in small cell lung cancer, especially in the relapsed refractory disease, we have miles to go before we sleep. But we are hopeful that given the enthusiasm with multiple agents being approved in small cell lung cancer and multiple agents in clinical development, I think there's more to enthusiasm in this field.